We are on MCA TV for Birth Congress 2018 in Venice, and we are with Professor Krzysztof Kuczkowski, Professor of Anesthesiology and Obstetric Gynecology in La Jolla, California, and also Vice President of Society for Intravenous Anesthesia. Welcome.
Yes, thank you so much, and good afternoon.
Which are the most important advances in obstetric anesthesia?
There are many. I personally consider obstetric anesthesia to be a science and art combined. And it's a very unique field to practice because you probably cannot find another subspecialty of medicine which provides as much gratification, personal gratification, as practice of obstetrics and obstetric anesthesia. And I actually trained as an obstetrician first. I was born and raised in Poland, and I worked for the biggest maternity hospital in the city of Łódź in English, in Poland. And I also did some subspecialty training in reproductive medicine, which was primarily done in the UK, in London, followed by a residency in anesthesiology after many years of practicing as a gynecologist and obstetrician. And I also did a fellowship in obstetric anesthesia at Columbia University in New York City in the United States. And trying to look at the perspective of obstetric anesthesia, it is a relatively new and still evolving subspecialty of anesthesiologists. I think, reached two landmark accomplishment last year. We had the first World Congress of Anesthesia for Obstetrics in February 2017 in Bali, in Indonesia, and in April 2017, Professor Giancarlo Di Renzo and his team organized the first World Congress on maternal-fetal and neonatal medicine, and I had the privilege of lecture on obstetric anesthesia at this meeting. Obstetric anesthesia is a subspecialty of anesthesiology which is dedicated to peripartum, perioperative, pain management, anesthetic management of women during pregnancy and the peripartum period. And what makes anesthesiologists unique is that we have training during our residency in acute pain management and in chronic pain management, which becomes very helpful. We also have extensive knowledge on critical care. And I think our job is to work closely with obstetricians, perinatologists, midwives, nurses in the labor and delivery room. And I think what it does, it helps us reach the highest quality of care we can provide to pregnant patients and their fetuses and then their newborn, which is wonderful, I believe. And obstetric anesthesia or labor analgesia is not a generic or standard procedures. And many various techniques have been developed over time. For example, most people think that labor analgesia is just continuous infusion of local anesthetics and opioids. It is, but it can be combined. Let's say we combined a spinal injection with epidural injection, and this technique is not really new, but I think it's, in my opinion, still underutilized, because I have always preferred combined spinal epidural analgesia for labor, which is abbreviated as combined spinal. Let me see, because we'll cut this, I hope. CSEA is technique. Sorry about this, because there are different terms, and I just wanted to use the most common one. And this one allows women to receive very small, like 1 milliliter of local anesthetics with opioid, very small amount of opioid, which goes to subarachnoid space. And then we put the catheter in the epidural space, epidural catheter, which allows the continuing infusion of local anesthetics and opioids. And I think it reduces the amount of local anesthetics and opioids used for the labor management, and patient satisfaction is much higher. And if they want, they might be able to ambulate in labor. I have always used 0.0625% of bupivacaine, which is the most common local anesthetic used, with a very small amount of fentanyl added, first to subarachnoid space and then to epidural space. And patients, if they choose, and if their strength of their lower extremities is okay, they can ambulate in labor. And I have actually provided a video to your colleague, Ms. Vittoria Paolini, showing two patients actually who were able to ambulate with the combined spinal epidural. And this clip is almost 20 years old. So what it does, it just sends a message that this is not a new technique, and it can be used in probably more hospitals and in labor and delivery rooms than it is. So I think this is something what I wanted to point out, that is worthwhile trying.
Okay, so we can say that obstetric anesthesiologists has unique skills. So what is their role in the peripartum period?
Well, provision of labor analgesia and anesthesia for cesarean section, because not all women who come to the hospital have normal spontaneous natural deliveries. Many of them, or not a significant part of them, might require some instrumental delivery or even cesarean section. And then our job is to provide adequate analgesia for labor and then anesthesia for cesarean delivery. And there are at least 4 choices. We can do a single dose spinal, which is a procedure lasting for 2 hours, 2.5 hours, which would be sufficient for most of the cesarean deliveries. We can do continuous epidural, either as a new anesthetic or extension of the labor analgesia with just different medications, stronger medications, to get a motor block to the level of anesthesia to T4, which is more or less here, which allows instrumentation in the abdominal cavity and extraction of the uterus and delivery of the fetus. We can do combined spinal epidural, which again, as I pointed out, combines the spinal block, the fast onset of spinal block with the ability to continue as long as the surgery lasts. Of course, there will be different type of medications, and concentrations will be different for both, because we need to get a higher level to be surgical anesthesia, not labor analgesia. And if duraxial blocks or regional anesthesia is not a good option, or if there are contraindications or the patient does not desire to be awake, we can always do a general anesthesia of endotracheal intubation. Some people do use supraglottic devices, but given the risk of aspiration, I think most of us would prefer endotracheal intubation of the pregnant patient following appropriate aspiration prophylaxis prior to induction of anesthesia. And of course, technique needs to be sterile and everything to avoid infections.